Pelzer with Illuminating Health, and today we are honored to be able to interview Dr. David Scheim on his recent paper on using ivermectin to treat COVID-19. Dr. Scheim, thank you so much for being with us today.
Glad to be with you.
Thanks. Dr. Scheim, can you start today by telling us what ivermectin is and why it was chosen as a candidate to treat COVID-19?
Ivermectin is a drug that was discovered around 1985. It's since been used to treat over 1 billion people worldwide for various parasitic diseases. And it was actually honored with the Nobel Prize, the person who discovered it, in 2015. It's a very interesting molecule. It's extremely cheap. It's used, in fact, to treat all kinds of animals for assorted diseases. So it's widely available.
Okay, thank you. So in your paper, you talk about the hydroxychloroquine, which has become very popular, but which people are realizing is problematic when treating late-stage disease. But you say that ivermectin, on the other hand, not only is it looking like it's more powerful than hydroxychloroquine, but that it can even treat in late stages. Can you explain to us the difference there, why that is?
It's the different pharmacology. The hydroxychloroquine has a strange pharmacology where if you take too much on any given day, it's toxic. There's a limit, that or chloroquine, which is very similar. And you really need several days, 5 to 10 days, to accumulate a tissue concentration that's adequate to have a serious sort of curative effect against COVID. So we find in the studies of hydroxychloroquine that it does very well in studies where people are given as early as possible when they get the symptoms, even before the test results come in. And, in studies where they only count positively confirmed patients, those treated early do extremely well. The thing is, though, a lot of patients don't really seek treatment until it gets serious. Now, ivermectin, the pharmacology of that is such that 4 hours after you take it, it reaches peak plasma levels in blood, and 4 more hours, it's distributed to peak in tissue. So within 8 hours, you have super high concentration. So the other thing about ivermectin that's very interesting that I focus on in my paper is that initially the standard dose for something like scabies for a human is 200 micrograms per kilogram. And that's standard for a lot of diseases. And if you go to the doctor, that's usually what they'll try to give you if you ask for it. But you can take 10 times that amount. There are many toxicity studies. 10 times that amount barely causes any problems. No serious adverse effects. With a serious disease like COVID, you don't want to take the low dose. And there are indications that there's a big dose response effect. And there are also indications that people who are using higher doses are getting much better results. Okay.
So you're talking about using ivermectin in much higher dosages. Can I ask you more about the specific data you have on that working better?
No, I don't. What I do in this paper, I give a very good review citing several studies that doses up to 10 times the standard dose are safe. Okay. That's clear. I give some reasons why one might think that you get a good dose response effect. Now, you really, if you're trying to do this scientifically, you can only look at a published study. You can't, I've been following conversations of people who have shared results, but unless it's really published, you can't go by it. What I would say is in the conversations I've had, the people are starting to use higher doses and they seem to be working a lot better. I can't, there's nothing definitive. The other thing is we do know that whenever you take a drug, over time, the level of the drug in your body diminishes. With ivermectin, ivermectin itself, the half-life in your body is about 18 hours, but it seems that the metabolites of ivermectin may be just as active, and they have a half-life of 3 days. So ivermectin may have a half-life of 3 days, but that means that people who take it once a week, even if the standard low dose was effective on day 1, by day 3 it could be a lot less effective, and by day 5 it could be doing nothing, and the virus can be regrouping.
See. Okay, so we'll try higher and more frequent. Let's talk about then the data that you do have in your paper, because when I did a search on Google Scholar for ivermectin and COVID, a lot of the papers are purely theoretical. But what made your paper stand out is that you cited real clinical data. So you have clinical data from Dr. Ryder in Florida using 173 patients on a prospective cohort trial. Can you tell me more about that, and if that group has any newer data that they also have out, like any randomized study trial?
Well, they are continuing to treat patients. In fact, I referred someone in Florida who called me just sort of by a fluke, happened to call me, and I referred them to their practice. But given that the spike in cases in Florida, I'm sure they're getting a lot more cases now. So I have been there. If you go deep into various ivermectin forums, there are people, especially in South America and the Caribbean, who are using it. And some people have been generous and shared information sort of confidentially with me. And I can sort of tell whether someone's credible or not. I have a sense of it. And again, I can't swear to it, but this looks very good. And one other thing, there's a lady in Atlanta who I know, and she kept telling me, I've seen something for ivermectin, because she used it with her pets. And because she had a dog who would always get scabies, she would get scabies once a year. So she would take ivermectin for scabies. And she saw something about that for COVID. And she asked me, does this look real or not? And I checked, and there were a few scientific studies. So I said, yeah. And then she did get COVID, and she took it. And just her response was so dramatic that it's always good, when you're looking at a study, if you know of a real life case, it gives you a little reality check.
Right. That's excellent. And in this study in Florida, they had about 100 patients who took it.
They had 173. And the thing, unfortunately in the paper, but something that Dr. Rader had told me, and something that first came out in news reports, somehow he didn't put this in his paper. I think this is the most important thing, is that several patients who went into a breathing crisis and who were losing breathing function rapidly, this is what happened with my friend. She took it once at the beginning of the disease. This is the first time it got serious, and the next day she thought she was cured. All her symptoms went away, and she didn't take it for 2 more weeks. But then she rapidly lost breathing function. From one day, the most minimal exercise, panting, the next day is just sitting down and having trouble breathing for 5 hours. And then she took the next dose of ivermectin. And then by that night, she was stable. And by the next day, she could walk around a little bit. And then within another day, she could take walks around the neighborhood and not have any big. So really, she just improved. It was very dramatic. And that's what Dr. Rader, that's what he reported it in a very good initial news article. He was reporting that, and he confirmed to me and that to me is even more striking than the mortality benefits, that it seems this is characteristic for a lot of patients, that it has a very quick dramatic effect.
And with total mortality, it seemed that was decreased about on the order of 50%.
Yeah. I think, though, someone in the Dominican Republic appears to be achieving, for hospitalized patients, something like 1% mortality versus the standard for that group of patients might be about 25%. It's not just with ivermectin, though, so you can't be sure. But when you look at what he's using, it really seems that ivermectin is the heavy hitter there. And There are some other drugs that also look good, like heparin. And ironic, what's very interesting is there's a molecular modeling study by Dayer that was, I think it's a preprint this year, that examined 100 different chemicals for the potential to block the binding of the SARS-CoV-2 spike protein. And of the 100, the 3 that were best were ivermectin, heparin, and azithromycin. It lends a lot of credibility because all of those have been found individually to have a significant anti-COVID effect. And so heparin is one, and so the Dominican Republic, they used heparin. There's a very good study where high and low molecular weight heparin together at a high combined dose of 27 hospitalized patients, including 8 on ventilators, none of them died, just with that and azithromycin. So heparin may block the spike protein just like ivermectin does, but ivermectin, there's more molecules. For a high dose of ivermectin, there's many more molecules than there would be of heparin.
So would you recommend using ivermectin and heparin together? And is that what they're doing, or is that a dangerous combination?
No, I think it should be fine. I mean, if someone if someone came in and got early symptoms and took ivermectin and azithromycin, that seems to be a good combination, or ivermectin and doxycycline. That's another antibiotic that has been found to have antiviral effects for this virus. Either one, that combination alone, if treated early, seems very effective. And it would be good. Now, I'm not a doctor. I'm not recommending, in any way a clinical recommendation, but it looks to me, if I got COVID, I would take it at 550 micrograms per kilogram. That's what my friend in Atlanta did. And it's just, why not, if you're unsure and it's safe at 4 times that dose, why take the tiny dose? If there's any question, take the larger dose and then repeat it every 3 days or so, maybe at 250 micrograms per kilogram, something like that.
There might be some individuals who are contraindicated, correct? If there's any issue with the
ivermectin is one of the safest drugs in modern medical history. Hydroxychloroquine has some contraindications for people who have heart arrhythmias. I just don't really know of any for ivermectin.
How about like pregnancy or a young child?
Even pregnancy, I don't, you can look at one can look at the literature for pregnancy. I'm really not sure, but it's one of the safest drugs. The only contraindication could be if someone has a compromised blood-brain barrier, because the ivermectin's main toxicities would be in the central nervous system, but it doesn't penetrate a normal blood-brain barrier.
Now, if it did get past the blood-brain barrier, would you be concerned about a lasting effect, or would it?
No, not as much. I think, and there are theoretically at least some advanced cases of COVID. You could have compromise of the blood-brain barrier, and if there's any sort of hint or suspicion of that, what one could do is take a lower dose over 2 days rather than take the bigger dose in 1 day. And it seems that when there are complications related at the higher dose, related to CNS, that they're not permanent. So, one has to really be careful with any drug you take. There's a certain, even the most commonly ones, is a certain low percentage of patients who will have serious effects. So, there are no guarantees with anything like this. But I think, when one has COVID, it's a pretty serious thing. And if the drug generally is very safe, it just seems to use it as aggressively as you can.
And would heparin be a good option for someone if there was a compromise in the blood-brain barrier? Is that safe for that?
Yeah, I think so. And one could use ivermectin if one had a serious case, why not throw everything at it? Ivermectin and heparin, and what seems to fit well is dexamethasone, which is Decadron. It's a steroid, and that's also safe, and that seems to go well in this mix. And of course, azithromycin, that seems to just be a good adjunct. It's used with hydroxychloroquine in the Marseille regimen, so azithromycin seems to be, as I mentioned, or doxycycline.
And let me ask you, because your paper has a great theoretical section about how COVID is affecting blood circulation and how that's similar to what happens in malaria, and how that explains why not just ivermectin, but really any drug that can be effective against malaria, you said seems to be effective against COVID, and that it also explains this thing they're observing with the type A blood.
Well, I think I was intrigued. I have been in correspondence with one of the researchers on the French team behind hydroxychloroquine, and they've done a lot of lab studies also. And he told me at one point that he tested a lot of other anti-malarial drugs, and most of them seemed to also be effective against COVID, which really got me interested, and it led to a whole interesting line of discoveries. And one of them is in malaria, the way the parasite gets in and infects the red blood cell is through the CD147 receptor. Now, people talk a lot about the ACE2 receptor, and that indeed is how, mostly how the virus propagates. It attaches to it, gets inside the cell, and then replicates. But the CD147 receptor is much more prevalent in the body than ACE2, and especially on red blood cells. There's about 1,700 CD147 receptors per red blood cell. There aren't any ACE2 receptors on red blood cells. Actually, even on tissues where there is ACE2, there might be like 1 per cell or something like that. So the malaria parasite, so that's one immediate insight, is to look at CD147. And it turns out that the SARS-2 COVID-2 virus binds to CD147. And this sort of led eventually to my hypothesis that what happens with the blood, and there's so many blood morbidities in COVID, what happens is that red blood cells bind to the virus and start making clumps, and then the virus can also bind to the endothelial lining of a capillary or blood vessel. So you start getting all kinds of these little catches and clumps that eventually, now if someone's blood is flowing fast enough, there's enough turbulence, these bindings aren't too tight. So they can they don't really take unless the blood flow slows down, but you can get a sort of positive feedback loop where you start getting a few of these clumps and they slow down the blood circulation, and then more clumps could form more easily. And what's really, so basically this led me to propose a hypothesis, catch and clump, which I called it. I wrote a preliminary paper. Then I found almost exactly the same thing, in fact, happens in severe malaria. And it's just astonishing. If you look at the figures, figure 1 is what I proposed for COVID. Figure 2 shows what's happening with severe malaria, and they look very similar. And one of the figures is an actual electron microphotograph of what's happening in severe malaria. And in severe malaria, these clumps are associated with the morbidities of the disease. And and then it turns out further that envelope viruses like COVID-2 routinely clump with red blood cells. In fact, it's used as a viral assay technique. And so now COVID doesn't specifically clump with the same receptor that other viruses do, but since the virus binds to CD147, it seems very, very possible that in the case of this virus, this is how it clumps. But it's sort of amazing that there are cases just as I proposed it. And let me just say one other thing. What's interesting about this hypothesis, it explains, number one, age dependence of the virus. The younger you are, the faster is your blood flow in general. It's much faster. Number two is blood type dependence. There are studies that find that if you have type A, you're most susceptible to COVID, type B next, and type O least. That's exactly what happens with severe malaria, because type A and to a lesser extent type B have some sticky receptors, and under normal conditions, those receptors wouldn't make cells clump. But if you have other things making it clump, then these kinds of receptors could just accelerate the clumping. And there's two other things that I just found that aren't in the paper. Number three is females have about 10% less red blood cells per liter than males do. And the less red blood cells you have, the less tendency there would be for them to clump. And number four, in serious cases of COVID, as the disease progresses, the hemoglobin level in blood goes down, which would clumping and catching and getting stuck in capillaries would account for when you do a blood test showing less hemoglobin over time.
And it's this clumping that causes the breathing difficulty, right?
The clumping would. Now, there clearly are lung effects. This doesn't explain everything, but there are so many effects that really do seem to be based in the blood. So if you there are people who you do the oximeter on the finger and they show a very low blood saturation, yet they seem to be fine. They're in the waiting office, texting and all that, and their oxat could be 65, which is really serious, and they seem to be fine. And this could be because their peripheral circulation is being hindered by this slowing of blood, by all these clumps. And so to get oxygen to the body, it has to first get it out of the lung from the capillaries flowing through the lung, and then it has to get it into tissue. And if there were hindrances in the circulation, it could definitely influence the oxygen transfer. And there are some real eccentricities in the way these people are having breathing problems that don't fit the typical lung disease scenario. So it could well be that all this blood-based clumping could account for much of what's going on with COVID.
And how does ivermectin affect the clumping?
Well, what ivermectin seems to do, according to this one molecular modeling study, which, as I said before, seems really credible because the 3 of 100 agents that came up as blocking the spike protein are agents that are, in fact, otherwise shown effective against COVID. But that what it appears is that the ivermectin binds to the spike protein, which if the spike protein is bound, it can't bind to any other cellular receptor. So that's what it seems to do. And it seems like a lower concentration might unclump the blood clots over time, depending on how far it's progressed, but it could start to unclump them. If you're not too far progressed, you could just have a dramatic effect where everything's fine within a day. And then if there was a higher concentration, it might actually block all the bindings to ACE2, in which case the virus just couldn't replicate at all. It would just be frozen completely.
It's impressive. Thank you. Can you also explain your paper? You were talking about the role of the immune system and making the clumps worse. Can you talk about that a little bit?
Well, it seems like these blood clumps, at least in malaria, we know that they have red blood cells and platelets. And in my figure 1, that's what I focused on. But it turns out there's a phenomenon called immune adherence, which covers viruses. And in that case, immune cells also, other white blood cells can get in the mix of these clumps. And white blood cells also have CD147 receptors, and they're sort of mobilized when a virus comes in and they get stickier. So it seems quite possible that white blood cells aggravate things further.
That's why maybe some of these treatments where they're tamping down the immune system, how that could actually also be helping.
Yeah, now the immune system, of course, aside from the clumping, it can just cause all other kinds of havoc if it gets overactive. But we don't want to neglect the possibility that it could actually join the mix of the clump cells. That could be another way that the immune system just is counterproductive. And actually, when red cells clump to viruses, this is in a way part of the immune system. The red blood cells, as well as white blood cells, can attach to pathogens and try to clear them. Mm-hmm. And immune adherence is sort of a phenomenon where the red cells first clump to the virus and then facilitate the binding of an immune cell to the virus because the red cell grabbed it first. So in a way, this whole clumping phenomena could be an immune system trying to do its job, but just going awry.
Thank you. Now, I'm just wondering, because you were talking about blood flow speed being an issue, and you think younger people, because they have faster blood flow, are able to get through this easier. I'm wondering if exercise is part of your daily routine. Do you think that would be protective?
I bet it would. You know, the thing is, you know, I forgot one other thing. I mentioned they found there's a recent study of risk factors. They examined thousands of patients and looked at risk factors. Patients who have a systolic blood pressure of 90 or less have a higher risk factor for COVID.
Oh, so low blood pressure.
That's right. And normally you'd think, gee, if you had like 90 over 60, you're as healthy as could be. But the thing is, every time the heart pumps, there's turbulence in the blood system, and that tends to break up clumps. So that's another sort of support for this theory.
So it'd be interesting if we try to keep patients moving. I know, unfortunately, a lot of people are being told to stay at home, and they might be moving less than they would ordinarily be.
Yeah, the thing is with COVID, once you start having breathing difficulties, then it gets harder to exercise. But for an early stage disease, it could actually be beneficial to get that blood flowing. If you know, it's again sort of a cascading process. If the clumps start, it slows down the blood flow, and that makes more clumps easier to form. If you can stop that whole cascade in the first place by getting your blood flowing rapidly, getting your heart pumping several times a day, I would speculate that this could really prevent serious disease.
Thank you. Just one more question. Do you know of any randomized clinical trials in progress? Do you know how that's going?
They are definitely in progress. I think there's 12 in progress. The thing about randomized clinical trials, unfortunately, there's sort of a pattern where big drug companies make drugs that don't work very well, and the only way you can see that they're working at all is by testing on hundreds of patients in a randomized controlled trial. If you have something that works really, really well and dramatically, you don't really need that. Like if we could do just a simple series of patients with ivermectin where it was carefully recorded what happened over the course of 48 hours, like just take various readings like oxygen saturation every 6 hours, I think we'd see dramatic cause and effect responses. We'd see a dramatic drop in mortality that would be so much that you wouldn't really need randomized trials. It could be done a lot quicker.
Or you could have a very small randomized trial. You just 50 or 100 people.
Yeah.
All right. Well, thank you so much for your time today. That was really interesting, and I'm just so glad we got to talk to you.
Okay, great to talk to you.
Thank you, Dr. Scheim.
Okay, take care. Bye-bye.